solvers to an early edition of RLR, where we have an amazing physician and friend and colleague, Jia, from China, who's going to be presenting today. Jia, when you are ready, please start, and Robbie will tackle the first aliquot, although I say that reluctantly because we have 45 minutes.
Stop talking. Stop talking.
Okay, so I think we can start this case. So today we have a 48 female from China who is present to the ED with fever, chest tightness, and shortness of breath for 1 month. And I will stop here. This is the chief complaint.
Oh my gosh, Gia. Well, for folks who haven't met you, we've been blown away by your cases. One that Andrew and Ravi discussed that kept me very humbled, and we're very excited for you to be presenting a case. And I'm already very intrigued. And I think the reason to be very intrigued is twofold. The first is that most fevers don't last a month, and that's very interesting. Yeah. And the other reason to be intrigued is to realize that there are not many ways and there are not many common scenarios where the chest tightness is accompanied by inflammatory disease. The vast majority of patients with chest pain and chest tightness have a bland, non-inflammatory profile. So I think the key to discussing this case will be to emphasize chest pain plus inflammation, and to emphasize, I have to look away from Prof. Rez to keep focused, smiling so hard, and to emphasize the duration. So those are I think the most diagnostically fruitful aspects of this case, but we have to stay anchored in base rate and make sure that we rule out the most important causes of chest pain no matter what. But those are the salient features that I think are important. Any other thoughts, Prof. Rez? All right, Gia, tell us more, please.
Okay, I will give you more information about this case. So the patient actually started experiencing abdominal distension like 2 months ago with an increase in abdominal circumference. And a few weeks later, she developed fever, chills, and fatigue with a max temperature of 38.5 Celsius degree. And at the same time, she developed chest tightness, shortness of breath, and mild abdominal pain. Her symptoms gradually got worse over the next months. And in the ER, the patient has orthopnea and a productive cough with the white sputum. She also has decreased exercise tolerance, and there is edema in her legs and the lumbosacral region. And she reports a decreased urine output recently, and there is no change in her weight. And I would stop here.
Gia, wow. First of all, you're such an expert presenter. I'm really excited to discuss.
Thank you.
Yeah, and I think the reason I want to applaud your presentation and your gathering of clinical data is because the sequence in which you presented is so helpful in us actually making progress on this diagnostic journey. And what do I mean by that? Gia didn't say this patient started with chest pain and cough. She said the patient started with abdominal distension. So whenever someone gives you the sequence of symptom onset, that really should aid in your diagnostic journey. And let's be honest, folks, oftentimes by the time we're seeing the patient, we already have imaging and data, unless you're Robbie and you're in the emergency department, but quickly you get that data. But even when you have the data and you see pathology, maybe in the lungs, maybe in the heart, maybe in the belly, the sequence will still help you in prioritizing the diagnosis. Abdominal distension comes down to the phases of Mater. And those phases of Mater include solid, liquid, gaseous states. Solid includes constipation. It's probably a very common cause of abdominal distension, but we know we're dealing beyond constipation. And I'm going to talk a little more, but I do want to throw up an alley-oop for Robbie because I think it's so interesting for him to discuss. Like, how do you explain fluid overload, but no weight gain? So I'm going to leave that for Robbie because it seems like this is almost we're heading down that route of anasarca, Robbie. So if you can sprinkle a little bit of the teaching. I know you've reflected so much on that topic recently, but I'm going to continue along this journey of the phases of matter. And solid also includes organomegaly. So for example, if someone's liver is enlarged, and you can easily imagine you're presenting to us, Gia, what seems to be an abdominal cardiopulmonary inflammatory syndrome. So if someone has some kind of hepatomegaly, it could affect the diaphragm. Or if they have cirrhosis with ascites, you can get hepatohydrothorax as a way of linking the abdominal pathology to the thoracic pathology. But once you tell us that she's having lower extremity edema and sacral stuff, I'm going to leave that actually for Rabih. It just points to the abdominal distension as being more consistent with ascites. So my greatest concern is this distension is ascites, and the next step would be putting an ultrasound probe on the belly to see if there's fluid or not. And if there is fluid, then we can activate our schema for ascites with regard to portal hypertension versus non-portal hypertension. But then you also tell us that she has this productive cough. So now all of a sudden you worry, like, is something infiltrating or causing inflammation of the liver and the lung? And then Rabih said a month of fever is unusual. So does that mean that we're prioritizing an atypical infection, be it mycobacterial or fungal or other? Not your common typical bacteria like S. pneumo, but more atypical like mycobacterial or their cousins that may involve the lung like actinonocardia. But one last thing I'll say is that even though she has a productive cough, what is to say that that isn't pulmonary edema? The sputum color, we've done a lot of studies on this. It doesn't really help with telling if someone has an infection or not. So could she have a cardiogenic etiology of the pulmonary edema and backup of fluid? It's all possible, but everything has to be explained through inflammation. And I think right now, infection, specifically atypical infection, is what's prioritized. Typical can still be involved, not in this scenario, but that's if you have the infection be walled off. And that's something we learned during one of our prior episodes, which I love that, Pearl. But I'm going to give the mic to Rabih because there's something really interesting about this fluid and no wake in and how he's processing it.
Yeah, Prof. Rez, I think you just made a compelling argument of what we think, what to think about, right? Like, made a compelling argument to prioritize a granulomatous or atypical infection. And I think what I'm honestly struggling with now, not struggling with, but trying to figure out is, where is the problem? And of course, that is a moot question because it's everywhere, it seems. It's in the chest and the abdomen and the belly. But understanding where the home base is and where everything else is a secondary complication will help us prioritize what kind of infection we're dealing with, of what kind of presumed infection we're dealing with. And I think it's tricky. So let me just outline the trickiness of it, which is, as you said, Gia's very advanced presentation skills give us the sequence of events. And you'd be very, very tempted to say, well, you know what? Her symptoms started with abdominal distension. So I'm going to venture to guess that the home base of this disease process is in the abdomen somehow. And that is a hypothesis that's reinforced by the fact that the subsequent events radiate outward from the abdomen into the legs and into the chest. But I don't think this is an abdominal disease, and I'll tell you why. The orthopnea may be simply the effect of the fluid compressing on her diaphragm when she lies flat, which makes it much harder for her to breathe. But anytime that you hear orthopnea, you should say, have I exonerated cardiac causes? And for me, the radiation of an abdominal disease to cause chest tightness is too far-fetched a leap. I can believe abdominal distension causing orthopnea, but the chest tightness makes me believe that this disease is actually taking up shop in the chest, as opposed to being a secondary consequence of either pressure, a secondary consequence of just pressure. I think the legs and the sacrum are secondary consequences of the pressure. I don't think there's any reason to believe that there's actual inherent disease in the legs. So for me, alarm bells are going off to the possibility of pericardial disease. Why? That's the most common location for inflammatory cardiac disease. And there's a term that describes this sequence of events, and it's called ascites precox. And the idea is that in some presentations of cardiac disease, the patient first manifests with ascites, followed by other signs of cardiac disease. So where is this disease is a mystery for me now, but why is this actionable? No, there is often no risk of imminent catastrophe in a patient coming in with 1 month of symptoms, but there are some exceptions. One of those exceptions is a pericardial effusion. So we can wait to see if she has liver disease. We can wait to see if she has ascites. We can wait to see if she has nephrotic or nephritic disease. We can wait, but we can't wait too much before excluding pericardial disease. So owing to morbidity, I think my first instinct is what's the status of the pericardium, followed by what's the status of the rest of the heart, followed by what's the status of everything else. So that's where I'd be thinking about the edema propres is just making sure we're not sitting on a malignant meaning sinister pericardial process. Everything else, we can kind of wait and see what the data says.
Robbie, I love that. I love that ascites precox. I've never heard that. And there is one thing that could be an emergency in addition to that, and that's this decreased urine output. So patients, like oftentimes we evaluate their kidney function based on their creatinine, but the creatinine is just a surrogate of what the kidney is doing. What's more prominent and more helpful is actually what is the urine. It's very rare for someone to say, I'm not peeing. And when you couple abdominal distension with decreased urine output, you have to worry about ascites and increase in abdominal pressure, leading to obstruction and decreased urine output. So in addition to evaluating the pericardium, I think it's really important to see what's going on with the degree of ascites, and is there pressure, and do you need to do the one instance you do an emergent paracentesis is exactly for this scenario if it is causing the decreased output. But it's very possible that the patient has a high creatinine and is hypovolemic and has ATN. But that's another emergency you have to worry about. When you have ascites, decreased urine output, do you need an emergent para? So one circumstance you do it.
Okay, so I will continue with the next aliquot, and actually I'm so excited to hear all these amazing talks and feel learn a lot of very new terms for me. So for the past medical history, the patient has uterine fibroids and received C-section like 30 years ago, and the patient was previously diagnosed with pulmonary tuberculosis at 18, but we could not get detailed medical records. And the patient isn't on any current medication. For the family history, her father has a history of TB as well. And the patient is a social drinker, non-smoker, and works as a rubber seller. She denies any recent travel history, and she lives in the northeastern of China. She is allergic to penicillin and cephalosporin. And for the physical examination parts, the patient is a febrile kind of tachycardia with a pulse around 110, respiratory rate is 20, and blood pressure is 120/80. The oxygen saturate is 96 at the room air, and her BMI is 27.6. And in the physical examination, the patient isn't in acute distress, and she has pale conjunctiva and lips, and her supraclavicular lymph nodes are palpable, painless, and mobile. They will cause thrills in bilateral lung, and the cardio examination is unremarkable. And her abdomen is distended without obvious tenderness, but she has rebound tenderness throughout the abdomen, and the bowel sounds is normal. The fluid wave test and the shifting Downey's test were all positive. There was 2+ pitting edema in the lumbosacral region and the bilateral lower extremities. And I would stop here.
Yeah, maybe I can just tackle the medical history and then dance with Prof. Rez with the exam. The medical history is very concerning for the significant exposure to TB. And I think that even if patients have received RIPE therapy, the chances of reactivation of their TB is low, but it doesn't mean that they are not at risk of reacquisition of the disease. So I think that's the big red flag in the history. There are a lot of gynecological issues that can present with volume overload, including malignancy, which is unusual in a premenopausal woman, but also some paraneoplastic gynecological issues from benign gynecological pathology. So those are in consideration, but in a very delayed manner. So we might come back to them, but the probability is we won't. That's my quick take on the background. So yeah, quick that was, Prof. Rez.
Oh, that was very quick. And Rabih, I think what we love to do here is to do like a hypothesis-driven exam because we take so much time in the HPI. And one of the hypotheses was, could this be a constrictive pericarditis, like a pericardial disease entity? And I just want to ask Gia, because we're not there to see the patient, did you feel like you could assess the JVP and hear the heart sounds, or was it a difficult exam?
Actually, like it's like case present in our group and not the patient I managed directly, so I didn't like see in the first case. Yeah.
No problem. I think the point I'm trying to make is that the physical exam is not as objective as data that we acquire, imaging labs. But if you were worried about constrictive pericarditis and you thought this was a pericardial process, there's some stuff you might see. One is a jugular venous distension, and you really got to get the patient upright because think about it. You got a pericardial pathology that's restricting inflow. And therefore you're going to see elevations in the right atrial pressure, and that manifests as jugular venous distension. Another thing you might see with constrictive pericarditis is Kussmaul sign. That is when people take a breath in, you have negative inspiratory force, and you should actually see a drop in this JVP, but you see a paradoxical distension, Kussmaul sign. So we don't have jugular venous distension. We don't have Kussmaul sign. Another thing, you might have a decrease in the heart sounds because of the space between the stethoscope and the actual valve closure where you get the heart sounds because of the pericardial process. None of this would say that I wouldn't get, like, we're still going to get an echo, we're still going to get a BMP, but it does, if you felt very confident in your exam and you don't have jugular venous distension, it really does take the focus away from the heart, and it gets it into the kidneys or the liver. The other thing to note is, along those lines, when you do get a BMP, this is the one instance where a normal value should not dissuade you from a pericardial constriction, because if the BMP is from the ventricle stretching, but you have this constrictive process, it's going to prevent the stretch of the BMP. So Rabih, all I do here so we can continue moving is to say our initial hypothesis of distension and volume overload is confirmed with ascites. The question is, what is the nature of that ascites? And ultimately, we'll use the echocardiogram to help us. But regardless, even I would do a diagnostic para in someone who's inflamed with ascites, because there's two things I want to assess. One is there portal hypertension or not? And two, is there SBP or not? Portal hypertension is based on the serum ascites albumin gradient. If it's north of 1.1, it's present. SBP is based on the number of neutrophils. North of 250, you have SBP. So those are the two questions I'm assessing, but I can't really make progress beyond that on the physical exam. I think additional data is going to help us, yeah.
Yeah, sure. Yeah, I will give
I'm so sorry. One last
additional...
thing, the lymph nodes. I totally overlooked that. The question becomes, is this just the tip of the iceberg, or is this disseminated throughout? And it's giving you a sense of inflammation. And so all of a sudden, lymphoma has to be thought of here in someone who's 48 with 1 month of symptoms and having volume overload, and lymphoma mimickers, which I won't even mention unless it becomes relevant. But that makes me want to get cross-sectional imaging of the chest, abdomen, and pelvis to see the extent of the lymphadenopathy.
Okay. So sure, next time we'll give more information about labs and then about imaging that everyone care about. So about the labs, the CBC reviewed white blood count at 20.7 with dominant neutrophil at 80%. Hemoglobin is 71 with MCV of 89, and the reticulocyte is 5%, and the platelet is 103, and the CMP reviewed sodium 143, potassium 3.7, chloride 107, and the carbon dioxide 28. BUN is 96, creatinine is 1.9, and her baseline is 0.7, and albumin is 3.2, transaminase, bilirubin were all normal, and the LDH is 156, lactate is 1.5, and the NT-proBNP is 2800. And the urine analysis reviewed proteinuria with trace red blood count, red blood cells, and the ESR is 110. The EKG reviewed sinus tachycardia, but no acute ischemia change. And I would stop here. Yeah.
Quick questions. Yeah. Do you have a spot protein to creatinine ratio too, by any chance?
You mean to TB spot or?
Oh no, not TB spot. The degree of proteinuria, was it severe proteinuria or was it?
Yeah, it's just between the range of 0.3 to 1 gram per liter.
Got it. Got it. And on the EKG, there was no decreased voltages, correct?
Yeah.
Okay, perfect.
Just tachycardia. Yeah.
I'm actually going to pass the mic to Robbie. I just want to ask those clarifying questions. I spoke a lot on the last aliquot.
Well, Prof. Rez, I think that we've now confirmed the nature of the inflammation, and the fact that it's neutrophilic predominant is profoundly helpful because it dramatically decreases the risk of lymphoma. Most lymphomas cause a mild leukocytosis and don't cause such a deep neutrophilia. The exception is Hodgkin's disease. So I think it really reinforces the notion, Prof. Rez, which is what you were suspicious of, is we have to prioritize an infection. And I think that infections that can last this long are either hidden in macrophages or hidden in macroscopic abscesses. And I think both those things get fair game. So I think what we're looking for is exactly what you suspected. Where the problem exists and where its home base is very tricky for me. There's signal towards the kidneys, much more impressively by the BUN than the creatinine, but both of them are prominent signals to look in the kidneys. And the problem is that the UA is giving a soft signal that the kidney is the home base versus the kidneys feeling the consequences of this abnormality elsewhere. And so while I think the kidney is an important consideration, I think the data isn't strong enough to latch onto the kidney. In stark contrast to if Gia had tweaked the case a little bit and made the albumin 2.5 and the proteinuria more prominent, then I think the kidney would definitely be the home base. What seems to be in proportion to the amount of abnormality is the degree of the BNP elevation. That fits in line with the cardiac, the degree of cardiac dysfunction. And so I think that if you ask yourself the two dimensions we started prioritizing, which is we have to figure out the time course, and then we have to figure out the inflammation. Now that there's evidence of cardiac disease, the question is what causes fairly acute onset heart failure over the course of a month, and what causes inflammatory heart failure? And acute heart failure, I think of in terms of the structures: endocardial heart failure, myocardial heart failure, and pericardial heart failure. And the things that are acute are in the endo and peri is any cause of effusive or constrictive pericarditis, and in the endocardial, any cause of inflammatory cardiac endocardial disease, usually endocarditis, but importantly, not to forget about rheumatic disease. In the myocardial category, the most common cause worldwide is acute coronary syndrome, for sure. But I think it's important to think about myocarditis as a cause. These are things that happen fairly acutely: endocardial, myocardial, and pericardial. What about the inflammatory disease? The inflammatory disease puts pericardial disease and endocardial disease and makes them more likely. So for me, I think the things that I would prioritize are blood cultures to make sure we're not assessing for endocarditis. You might think about a review of systems to see if there's been any recent evidence for rheumatic fever. But I think the next step is an echocardiogram to really try to evaluate the cardiac manifestations of this disease process, and to also follow up the UA with more refined urinary testing with a urine protein to creatinine ratio and microscopic analysis to see if these RBCs are glomerular or not. I think, as a general rule, heart failure accompanied by tachycardia is unusual. And again, for me, makes a rare condition the most actionable right now. So a final thing I'll reflect on, Prof. Rez, and I'll just ask you to reflect on it. I'm just like free flowing. I'd be really worried about what to do for this patient, because I think everyone's instinct would be to diurese this patient. A lot of volume, but I wouldn't. I wouldn't for two reasons. She's inflamed, and I'm still worried about pericardial disease. But yeah, what thoughts do you have to layer on, Prof. Rez?
I absolutely love that. I really don't have much thoughts to layer on. I think something that did grab my attention was this bicytopenia of the anemia and the thrombocytopenia. So along the lines of your thinking, if you did have endocardial disease, could you be dealing with a MAHA? So I would be interested in a peripheral blood smear, or are we dealing with DIC? And this would prompt me to send the smear and like fibrinogen levels. And then I would also want the cross-sectional imaging, Robbie, in addition to the echocardiogram, just to see the extent of lymphadenopathy. But I love your point of home base probably being the heart, and myocardium, endocardium, and pericardium, all three are possibilities here. And that echo will help us make tremendous progress.
Okay, so I will continue with the Raman labs and about the imaging. So for the blood smear, there's no schistocyte and just the red blood cell in different size. And the ion panel revealed ion 26, ferritin 399, transferritin saturation 15%, and TIBC 168. And the Coombs test is negative. The ascites fluid test revealed albumin 1.7, protein 2.7, and the ADA is normal at 2.2. The neutrophil cells is 59, and the Revolta test is negative. Just a little information that the Revolta test is kind of an additional test that's commonly used in China to distinguish the exudate and transudate, and positive test may suggest exudate. And the autoimmune panel reviewed normal immunoglobulin level, normal ANA, normal ANCA, and normal anti-GBM antibody, all negative. The C3 is slightly decreased, and the ACE-PAP is negative. Serum immunofixation reviewed positive IgG kappa lines, and the free light chain reviewed the normal kappa and the lambda ratio. Blood culture all come back all negative, and the blood T-spot TB is negative. The passenger test for the ascites fluid come back as negative in bacteria, fungi, or mycobacteria, and I would stop here.
Jay, can I ask just one question? So it sounds like the serum ascites gradient is high at 1.5. The serum, the ascites
it's
albumin.
It's
1.5.
1.5. Yeah.
Do you happen to have this serum ascites total protein?
Serum ascites total protein.
Sorry, not serum, just ascites total protein. I know you said ascites.
The total protein is 2.7. Yeah.
In the ascites. Okay.
Ascites protein. Yeah.
Okay. All right.
Let me see.
Very, very helpful. Hi, Prof. Rez. I love your text. Thoughts?
So this is fascinating, and Can we just ask one more question, Gia? Because I think it would be really helpful
Mm.
for us here. The echocardiogram, can you give us that information?
Yeah, sure. I can give you that information now. It is very important. Like the echocardiogram revealed decreased left ventricular diastolic function, and there is a moderate pericardial effusion and also pericardial thickening. Yeah.
Okay, so this is really, really helpful. And just like Robbie suspected,
Yeah.
what was the term? Ascites precox?
Prof. Rez, I can't tell you how yeah, I just love medicine. Like the I my only reflection, I'd love for you to dissect all this data, but since you opened that door, I'll just say this. We've been talking so much about how the history has the answer in so many cases. I mean, I think that history really, really is a beautiful pericardial history. And I'm really glad that that you guys found it. And I think it's key to analyzing this case. But Prof. Raz, I'd love for you to dissect this and maybe even share the thought that you texted me, because I think it's a really cool one.
Absolutely. And maybe I'll start with the thought that I sent to Robbie, and that was really we have a patient who has thrombocytopenia, has anasarca, has organomegaly in the terms of like lymphadenopathy, and has fever. So thrombocytopenia, anasarca, fever, organomegaly. Not that the F stands for fever, it stands for reticulin fibrosis, but it made me think of Tafro syndrome. Tafro, which is a type of idiopathic multicentric Castleman disease that's not associated with HIV and HHV8. So it's something that came to mind. I'm not sure the diagnostic criteria, besides trying to meet each of those letters, maybe a bone marrow would help confirm that. But I think it's one thing to consider, but really you have to go to where the money is. And the money right now is all in that pericardial space. So the question is, what causes a pericardial pathology? And in this patient, you're really going to assess for pulsus paradoxus. And on that echo, you're going to see if there's right ventricular invagination during diastole to suggest tamponade physiology. And that's why the EKG was so important, because not only were we looking for low voltage, but we were looking for beat by beat variation in the amplitude of the voltage, known as electrical alternance. Whenever you have a pericardial effusion, a lot of times it's idiopathic, but in this case, it won't be idiopathic. And I don't think you can just say pericardial effusion, because that can be from thyroid disease, it can be from uremia. You should say inflammatory pericardial effusion. So I think, Robbie, really the job here is to ask the question, especially in light of the negative ANA, making an autoimmune etiology less likely, what kind of infection might be involving the pericardium, if it is an infection, or are we dealing with something like Tafro? Regardless, given the symptoms that this patient has, I would actually consult interventional cardiology or cardiothoracic surgery to help both drain and manage this patient's fluid, meaning from the pericardial space, because that increase in pericardial pressure is limiting the heart's ability to pump blood forward. So I would do a pericardial synthesis and maybe pericardial stripping to both diagnose and treat this patient. But for me, it's like, is there an infection there, or can this be part of a lymphoproliferative disease with that IgG spike, like Tafro, idiopathic multicentric Castleman's? Robs?
Professor, I completely agree with you, and I think that as people on RLR will learn soon, I've been diving deep into pericardial effusions and presented a very complex case, not as complex as this one, to Prof. Rez, and I think that the tension in this situation that people in real life might be facing with is the reality of how hard it is to diagnose TB, and already I think the conversation about empiric ripe will probably be happening, because you have a patient who is in a TB endemic region who has a subacute inflammatory pericardial effusion. And so I'm just anticipating that no test will be able to eliminate TB until the cultures come back 6 weeks from now. Can't wait for that. So in addition to the diagnostic testing, I think empiric ripe is a practical conversation that people will be faced with. All right, Gia, mic to you. Yeah.
Okay, so for the rest of the testing images, the bone marrow biopsy come back as normal, and the lymph nodes ultrasound is normal as well. And the right, we did the right heart catheter, which come back as normal pressure. And the liver ultrasound, portal hepatic veins ultrasound, were all normal. The CT scan reveals bilateral pleural effusion, pericardial effusion ascites, and the pelvic effusion, and localized thickening in bilateral pleural, and very instantly found a mass in the anterior mediastinum. And then we did the further PET-CT, which revealed increased metabolism in the lesion of the anterior mediastinum with this UV of 4.9, indicating possible malignancy. And I would stop here, left the last article.
That's very fascinating. I think this case is moving at such a high pace. And I think, Prof. Rez, what we found now is that the summary, I think, is that this patient has the home disease in the chest. And now there's been a dramatic addition to that, with that this patient has a mediastinal mass. And I think not only is it a mediastinal, it's an anterior mediastinal mass. And whenever you hear anterior mediastinal mass, there's a mnemonic of the 5 T's, but 2 of them are much more common than anything else. And that is a lymphoma and a thymoma. A thymoma is usually associated with paraneoplastic phenomenon that are not as hectic. So I think you should say, wait, this is an anterior mediastinal mass. And there is a hectic presentation. How could this not be lymphoma? And I think that the possibility of lymphoma now looms very, very large. It is also, I think, very congruent with your history of what you said earlier about could there be Castleman's disease and paraneoplastic manifestations of Castleman's disease, such as Tafro. And I think that's another really important consideration. But it is also possible, unfortunately, to have TB and histoplasmosis in a semi-fibrosing mediastinitis manner show up as an anterior mediastinal mass. So I think the next step is probably a little bit more clear, is you probably need to sample this mass because the disease has been kind enough to coalesce there for you to look under the microscope. Finally, one place to go after. If this is a lymphoma, I think the only lymphoma that would make sense with my current knowledge base to cause a neutrophilic leukocytosis is a Hodgkin's lymphoma, which is totally fair game as it's one of the most common in the anterior mediastinum and is fair game given the patient's age. I think Castleman's would be a great unifying diagnosis with Tafro, but just because there's an anterior mediastinal mass does not rule out infections, with TB and histo being the leading causes and TB being center stage here based on what we've heard so far. Your thoughts, Prof. Red?
Man, that's poetry, Robbie. And I just want to mention one thing before I hop off, and that's the following. When you are concerned that because a lot of people have pericardial effusions and it doesn't cause any kind of derangement. And really in this patient, I think it's important, and I'd love to hear your thoughts, that we tackle this, Robbie, because we were saying everything was starting in the pericardium. But what we do know is that we have panserositis, the 3 Ps, peritoneal ascites, pericardial fluid, and pleural effusion, the 3 Ps, panserositis. The right heart cath, they can actually assess measurements to say, is there constriction or not? Or is there restrictive pathology or not? I think that's such an important point, not from a diagnostic perspective per se, but more from a management perspective. Because if you have that thickening of the pericardium and constriction, you need to alleviate that if that's what's driving all of this. But now, I don't know what you think, Robbie, I'm getting a sense of more of a diffuse inflammatory process. And I'm trying to tease out, and this is more advanced reasoning, how much of it is just from the pericardium versus diffuse inflammation causing fluid overload, and you happen to have the pericardium. Thoughts on that before I have 1 minute left, brother? What do you think?
I think it's 50-50, and the only data that we have is to look at the ascites and study, is it inflammatory or not? And the ascites sag suggests a pressure mechanism, and the total protein in the ascites of 2.7 suggests that that pressure is cardiogenic in origin. So it's a mystery to me why the right heart pressures are normal, and they seem incongruent with the data from the actual tab. So that's why I say it's 50-50. It depends on which one you trust. I don't know which one to trust, quite
I
honestly.
love that point. Unfortunately, I have to log off.
I'll fill you in, okay?
Robbie, thank you, man. Thank you for teaching me ascites precox. I'm gonna say
Well,
it
I don't
on
know.
round.
We'll
I have a
see.
patient with ascites. I'm gonna say it on rounds today.
You got it. Oh my gosh. All right, Gia, tell us what did you get next?
Okay, so next we got the biopsy of this mediastinal lesion, which just revealed fibrous and connective tissue. And however, the mycobacterial culture come back as positive from this tissue, and but the mycobacterial tuberculosis antigen was negative. So we further test the nucleic acid test for both the TB and the NTA, but all come back as negative. And actually, during this patient's hospitalization, we did repeated times of blood T-spot TB, which came back as positive. And the ascites fluid test also run a lot of T-spot TB tests. Initially came back as negative, but final in the last 1 to 2 times come back as positive. And during the patient hospitalization, she received the 4-drug anti-TB medications, and also the prednisone to improve the pericardial adhesion. And also she received the clarithromycin for the NTM. And after 3 months of treatment, she repeated the CT and the echo, which showed elevated thickening of the pleural and the pericardium, and also decreased the size of the mediastinal lesion. Yeah.
Yeah, this is an unbelievable case.
Yeah.
It really, yeah, I'm really just in awe of the story itself. But honestly, more impressed by, as you're seeing in the chat, your ability to dissect this case and share this case and set it up the way you did is reflective of a tremendously advanced knowledge structure, tremendous presentation skills. If you were in the US and there was an attending was giving you feedback on your presentation, it doesn't get any better than this. Really, really doesn't. So thank you so much. I'm very curious. Unfortunately, it's just such a we appreciate your flexibility to change the time and everything. And I'm sorry that I have to leave a few minutes early. I'm just curious about one thing, which is when you got the mycobacterial culture positive, could they identify it as TB, or could they just identify it as a mycobacterial organism?
Just a mycobacterial organism. So we run the nucleic acid test, but we thought this lesion is not so likely to be contaminated. So we just treat it as TB. Yeah.
And at the end of the day, I think there's so many learning points in this case, and I'm really excited to listen to Ibrahim's car version of it when I watch this later on YouTube. But I think the history and the first aliquot conversation is what I would really recommend that people focus on, because you heard Prof. Ressa's discussion and how he immediately said, I know what I'm looking for. I'm looking for a hidden infection. And that was turned out to be true. And then you heard the reflection on where. And I think those two questions are what and where are really, really key in solving this problem. And the final thing that I'd encourage you all to recognize is that the best test for tuberculosis is response to therapy. As you see here, this is it's such a complicated diagnosis to make, but the therapy is very effective unless the organism is resistant. So fantastic case. Really, really learned a lot from discussing it. Excited for you to be more in sync time-wise with VMRs. We have a lot to learn from you and a lot to share together. So thank you again. I'm curious, before we learn from Ibrahim one more time, who I'll make the host What reflections did you have from taking care of this patient?
Yeah, I
From
just
being
feel like
involved?
in this picture there are lot so many information. Just like you said, like we should know which part we should pay our attention most to grab the keys, and also I feel like the TB is a very tricky bug. That's sometimes it is very hard to find the evidence, and in some case we have to try first. Yeah.
A superb takeaway. I couldn't agree more.
Mm.
All right, Ibrahim, we're ready for you. I also made you the co-host. So I will listen to mobile teaching from Ibrahim on YouTube. So please don't forget to end the meeting. Otherwise, we'll catch you on your road trip the rest of the time. Okay?
Yeah, no
Bye,
worries.
everyone. Happy Friday.
Bye. Okay, so this patient had a fever for 1 month when we first heard about the case. And if you hear a patient who's having fever for more than a month or a month, this should be basically a red flag, because most infections out there would not result in a fever for a month, especially with the chest tightness. And then if you'd like to localize the symptomatic presentation of the patient, you need to think about the tempo and the progression of the symptoms. So in the HPI, we heard that the patient had abdominal distension first. However, that being said, if the patient also had a chest tightness, just like our case, this increases the pretest probability of a primary pulmonary involvement. And so you need to think about pericardial disease. And Rabih has taught us about something known as ascites precox. And ascites precox is a term that is used to describe the appearance of ascites in the abdomen prior to the appearance of generalized edema secondary to the cardiac involvement. And then for the abdominal distension and how you would think about it as if you're thinking about the states of matter. That is solid, liquid versus gas. Solid, you need to consider organomegaly, and organomegaly can be due to infiltration secondary to a malignancy, or it could be due to infiltration by an atypical infection. And an atypical infection should be thought of if a patient had prior exposure or a history of TB, such as our patient. And then you also need to consider that reinfection can sometimes occur. And then for the liquid, you need to consider ascites. And if you're considering ascites, you typically go for a point of care ultrasound. And then finally the gas, as we've mentioned. And then for the decreased urine output is also a red flag, in a sense that often we use creatinine as a surrogate to actually look at the kidney function. However, urine output is often higher yield. And so this may be secondary to ascites and may require you to order a paracentesis to look for portal hypertension and spontaneous bacterial peritonitis. And then if you're thinking about the pericardium, just like our case, you need to look for elevated PVT, Kussmaul sign, and decreased heart sounds, since this would increase the pretest probability. If they're absent, it would decrease the pretest probability, but you may still need to order a BMP in order to rule it out entirely. And then for the lymph nodes, think lymphoma versus lymphoma mimickers, and you would typically order a chest, abdomen, and pelvis CT to assess for lymphoma. So for the labs, we heard that this patient had a neutrophilic predominance on CBC, and this lowers the lymphoma probability, the exception being Hodgkin's lymphoma. And then we also heard that this patient had a very high BMP, which again reemerged as a cardiac cause for this patient's presentation. And when evaluating a patient with a very high BMP and thinking about a primary cardiac cause, you need to think about the layers of the heart themselves. So the endocardium, the myocardium, and the pericardium. And you need to think about effusive, constrictive, or infective etiologies, but never rule out coronary artery disease. And then finally, we also heard about something known as Tafro syndrome. This is also known as idiopathic multicentric Castleman's disease, and it presents with thrombocytopenia, anasarca, fever, reticular myelofibrosis, as well as organomegaly, which seem to fit this patient's presentation. And then also, if you're thinking about inflammatory pericardial disease, in a sense, in the picture of Tafro patient, you need to look for electrical alternance and order a pericardiocentesis or a biopsy for a final diagnosis. Also, if a patient is coming from an area that has a predominance with TB infections, you may consider empiric Lyme infections while you're waiting for the TB culture to come back. So I think that's all for our session today. Thank you all for being here, and we'll see you tomorrow.
See you. Have a good day.